Hi, today's topic is metastatic tumors of the orbit, the anophthalmic socket in the craniosynostosis. So the first one is adult metastatic tumors. The orbital metastases are infrequent cause of proptosis and much less common. Why? Because in the metastasis to the choroid is more common than metastasis to the orbit. If the orbit is the site of initial manifestation of the tumor, then the ophthalmologist may be the first specialist to see the patient. In approximate order of frequency, the most common primary site are the breast, up to 70%, and then the bronchus, then the prostate, and then the skin. And the skin melanoma can spread to the orbit, the gastrointestinal tract, and then the kidneys. Signs associated with the range of tumors that can spread to the orbit. Presentation can take a variety of forms. Presentation can be in the form of dystopia and proptosis. The most common feature is dystopia and proptosis. Second is infiltration of orbital tissues characterized by ptosis, and diplopia, brawny and indurated periorbital skin, and a firm orbit with resistance to manual retropulsion of the globe. In ophthalmos with serous tumors, chronic inflammation, primarily with cranial nerve involvement, cranial nerve 2, 3, 4, 5, 6, and only mild proptosis with orbital apex lesions. Extraocular muscles can also be involved, and bone marrow species of the sphenoid bone. The imaging CT and MRI typically show a non-encapsulated mass. Fine needle biopsy is useful for histological confirmation. If this fails, open biopsy may be required. A search for primary must be carried out if the patient was not previously known to have cancer. Treatment is aimed at preserving vision and relieving pain. Because most patients die within a year, average 4 months. Radiotherapy is the mainstay of local treatment, but systemic therapy may also be of benefit. Surgical excision of the focus is occasionally carried out. Orbital exenteration is usually only performed if other modalities fail to control the intolerable symptoms. Now the childhood metastatic tumors, in which the first one is neuroblastoma. The neuroblastoma is one of the most common childhood malignancy. It arises from neural crest derived tissues of the sympathetic nervous system, most commonly in the abdomen. Presentation is usually in early childhood. In almost half of all cases, the tumor is disseminated at diagnosis, when it carries a very poor prognosis. Orbital metastasis may be bilateral and typically present with abrupt onset of proptosis, accompanied by a superior orbital mass and lead ecchymosis. Here you can see in this picture. So this is neuroblastoma in this picture. Then myeloid sarcoma. Myeloid sarcoma, also known as granulocytic sarcoma. It is a solid tumor composed of malignant cells of myeloid origin. Because the tumor may exhibit a characteristic green color, it was formerly referred as chloroma. Myeloid sarcoma may occur as a manifestation of established myeloid leukemia, or it may precede the disease. Orbital involvement usually present at about age 7 years, with the rapid onset of proptosis, sometimes bilateral, and can be associated with ecchymosis and lead edema. When orbital involvement precedes systemic leukemia, the diagnosis may be difficult. Next is Langerhans-Hill histiocytosis, a rare group of disorders due to clonal proliferation of histiocytes. Presentation ranges from localized disease, usually with bone destruction, eosinophilic granuloma, through multifocal bone involvement to a fulminant systemic disease. Soft tissues are less commonly involved, but cutaneous and visceral lesions may occur. Orbital involvement consists of unilateral or bilateral osteolytic lesions and soft tissue involvement, typically in the superior temporal quadrant. Patients with solitary lesions tend to have a more benign course and respond well to treatment with a local curettage and intralesional steroid injection or radiotherapy. Systemic disease has a worse prognosis. So this is Langerhans-Hill histiocytosis. Then orbital invasion from adjacent structures. Number 1 is from sinus tumors. Malignant tumors of the paranasal sinuses, although rare, may invade the orbit and carry poor prognosis unless diagnosed early. It is therefore important to be aware of both their otorhinolaryngological and ophthalmological features. Maxillary carcinoma is by far the most common sinus tumor to invade the orbit, and otorhinolaryngological manifestations include facial pain, swelling, epistaxis, nasal discharge. Ophthalmic features include upward dystopia, diplopia, and epipora. Ethmoidal carcinoma may cause lateral dystopia. So maxillary cause upward dystopia, ethmoidal cause lateral dystopia. Nasopharyngeal carcinoma may spread to the orbit through the inferior orbital fissure. Proptosis is a late finding in this nasopharyngeal carcinoma. Bony invasion, intracranial meningioma arising from the sphenoid ridge may invade the orbit by direct spread or cause proptosis. Occasionally, tumors arising from the tuberculum, cilia, or olfactory groove may invade the orbit through the superior orbital fissure or optic canal. Fibrous dysplasia. Fibrous dysplasia is a disorder in which the fibrous tissue develops instead of normal bone, leading to weakening and mass effect, usually in childhood or early adulthood. Within the orbital region, this may cause facial asymmetry, proptosis, and dystopia, and visual loss. Most orbital disease is due to monostotic form. Polystotic disease is associated with endocrine disorders and cutaneous pigmentation, called McCune-Albright syndrome in 10% of cases. This coronal CT scan shows involvement of the floor and medial wall of the right orbit. Here in this picture, there is facial asymmetry, proptosis, dystopia, and vision loss. Here you can see polystotic disease, which is associated with endocrine disorders and cutaneous pigmentation. Orbital invasion from eyelid, conjunctival, and intraocular tumors. Orbital invasion may occur from eyelid malignancies such as basal cell carcinoma, squamous cell carcinoma, or sebaceous gland carcinoma, from conjunctival tumors such as melanoma, and from intraocular tumors such as choroidal melanoma and retinoblastoma. Now the anophthalmic socket. An anophthalmic socket is an orbit which do not contain an eyeball. So it is an orbit which do not contain an eyeball, but the orbital soft tissues are present and the eyelid structures are also present. It is rarely congenital, but usually it is acquired. Surgical procedures, the removal of an eye or the contents of the orbit may be indicated for intraocular or orbital malignancy, or where the eye is blind and painful or unsightly. A number of different surgical and rehabilitation techniques are available. The first one is enucleation. Enucleation or removal of the globe is indicated in malignancies. In enucleation, first releasing the extraocular muscles from the sclera, and after the releasing of the extraocular muscles, then the globe is removed. Its indication are primary intraocular malignancies, where other treatment modalities are not appropriate. The tumor is left intact within the eye for histopathological examination. After severe trauma, where the risk of sympathetic ophthalmitis may outweigh any prospect of visual recovery, and blind, painful or unsightly eye can also be managed by enucleation, although evisceration is generally considered the procedure of choice. So the malignancies are retinoblastoma and choroidal melanoma. Then we have evisceration. It refers to the removal of the entire content of the globe, and the sclera and extraocular muscles remain intact. Generally, the cornea is removed to provide access to the ocular contents. Retention of the sclera and lack of disruption of the extraocular muscles provide better motility than is achieved after enucleation. Evisceration provides disrupted and incomplete material for histology and should not be undertaken in the presence of suspected intraocular malignancy. So it is there is better motility, there is incomplete material for histology, there is less disruption of orbital anatomy, treatment of endophthalmitis, easier prosthesis petting, and decreased extrusion of the implant. Now the exenteration. Exenteration involves removal of the globe together with the soft tissues of the orbit. So the eyeball and adjacent intraocular tissues with or without the skin of the eyelids. Indication of the orbital malignancy, either primary or where a tumor has invaded the orbit from the eyelids, conjunctiva, globe or adnexa, when other forms of treatment have a very poor chance of success. Anteriorly sited tumors may allow relatively sparing of the posterior orbital tissues, and posterior tumors may allow sparing of eyelid skin to lie in the socket. Following exenteration, prosthesis can be attached to the surrounding skin with adhesives, or the prosthesis can be mounted on glasses or secured. The prosthesis can be secured with osseointegrated magnets which are mounted on the orbital rim bones. The socket may be lined with skin or a split skin graft or left to heal by secondary intention. The other indications are non-malignant disease such as orbital mucormycosis. It is a rare indication. Here you can see the prosthesis attached to the glasses or skin adhesives. There is healed exenteration. There is exenteration including eye removal 2 days post-operatively. Here is exenteration with sparing of the eyelids in posterior tumors. Here is osseointegrated magnetic coupling implants in the right orbit after exenteration. There is front view of the orbitofacial prosthetic and orbitofacial prosthesis in place using magnetic fixation, showing excellent contour to the skin. Rehabilitation is done with orbital implant and an ocular prosthesis. The volume of an enucleated eyeball varies between 7 and 9 ml. After the surgery, a conformer is placed in the socket as a placeholder for the future prosthesis. Here you can see a conformer. In these pictures also conformer. Now first of all, the orbital implants. Enucleation or evisceration leads to a reduction in the volume of the orbital contents. A large prosthetic eye without an underlying orbital implant does not provide a satisfactory solution due to stretching of the lower lid under its weight and to poor motility. An implant is usually inserted during surgery at which the eye is removed, though secondary placement can be performed later or a previously inserted implant exchanged. Implant materials may be solid, non-integrated, right? For example, silicone and acrylic, or it may be porous, integrated. For example, polyethylene and hydroxyapatite. Fibrovascular ingrowth into the porous material facilitates motility, often overlying prosthesis. A peg can also be inserted into the porous implants to improve motility, though the peg must be covered in situ by socket tissue and cannot attach directly to the overlying prosthesis. Here you can see silicone 18 mm, hydroxyapatite 20 mm, porous polyethylene 20 mm and silicone 22 mm. Here you can see visceration with methyl metacrylate spear and prosthesis. Methyl metacrylate spear placed within the muscle cone, and here methyl metacrylate spear in the muscle cone and prosthesis. Non-porous after evisceration placed in the scleral bag. Here you can see hydroxyapatite implant in enucleation from coral interconnected pores allows placing of a peg, so there is good motility. Here is the dermis fat grafted hip or groin area. It is taken from hip or groin area. It is fed to restore orbital volume, and dermis that provides vascular support. It is perfect biocompatibility and tendency to atrophy. This is a dermis fat graft 3 days after surgery. These are ocular prostheses. Here you can see before empty socket and there is matching prosthesis in place. Ocular prosthesis after enucleation or evisceration, a conformer made of silicone or acrylic material is placed to support the conjunctival fornices and remains in place until the socket is fitted with artificial eye. Initial socket impression molds can usually be taken at around 6 to 8 weeks post-operatively, and a temporary artificial eye placed whilst the waiting for manufacturing of a prosthesis shaped to fit the individual socket and match to the fellow eye. Post-enucleation socket syndrome (PESS) is caused by failure to correct the volume deficits adequately. It is characterized by a deep upper lid sulcus, ptosis, here you can see, in ophthalmos, and backward rotation of the top of prosthesis. Next is extrusion. Extrusion is a significant concern with all implants, and careful placement of an implant, ensuring it is sufficiently deep and is well covered with vascularized tissue, is more important than the choice of implant material. Next is craniosynostosis, a group of rare congenital conditions in which an abnormally shaped skull results from premature closure of skull sutures. So there is abnormal shaped skull, and due to premature closure of skull sutures, the first one is Cruzen syndrome. There is short anterior-posterior skull diameter, mid-facial hypoplasia. There is prominent lower jaw, proptosis due to shallow orbit, hypertelorism, which is wide orbital separation, and the most conspicuous ocular features. Vision-threatening complications include exposure keratopathy, optic atrophy due to chronic papilledema, and cerebral hypoperfusion secondary to sleep apnea. Strabismus is V-type exotropia. Ametropia, amblyopia can occur. Other ocular situations have been noted. Inheritance is usually autosomal dominant. Allelic variant in the gene FGFR2 are responsible. Apert syndrome is the most severe form of craniosynostosis. Oxycephaly, which is conical skull, mid-facial hypoplasia with a beak nose, low-set ears, syndactyly, and developmental delay 30% may be present. Shallow orbits, proptosis, hypertelorism generally less pronounced than Cruzen, but the same vision-threatening complications can occur. Inheritance is AD, but the majority of cases condition is sporadic and associated with older parental age. As with Cruzen syndrome, it is frequently the result of mutation in FGFR2 or mutation. Thank you very much.